Hi everyone, I am Dr. Osama Yassin Mansour, Professor of Neurology and Interventional Neuroradiology and Director of Stroke and Neurointervention Center, Alexandria University, Egypt. Today I will present a case of AV Fistula Cognard type 4, draining into the vein of Labbé, which underwent embolization, but dissection, migration, and shock, a full spectrum endovascular crisis. Our case today is for a 30-year-old male who presented with a sudden, severe headache. Neuroimaging showed left temporal hematoma. DSA showed dural AV left temporal fistula cognard 4 to the vein of Labbé. Embolization via external carotid feeding vessels, the middle meningeal artery and superficial temporal artery, was done successfully with occlusion of the fistula. However, during microcatheter retrieval, a fragment of embolic material migrated into the central and postcentral MCA territories. Multiple attempts were made to retrieve the solidified embolic fragment, reflecting the complexity and urgency of the situation. Eventually, the fragment was maneuvered into the M1 segment, where a combined stent retriever plus aspiration technique successfully removed it. Thought that nightmare ended, injection of the common carotid artery revealed a dissection of an ICA cervical loop, which occurred, leading to progressive ICA occlusion and embolic spread to both the 1 and M1 territories. I endured the nightmare, trapped and unable to wake. I began preparing to fight a fierce battle to remove the clot. A 1-pass thrombectomy was performed, achieving complete TISI 3 reperfusion. Due to recurrent reocclusion, a balloon-mounted stent stabilized the dissection. Dual antiplatelet therapy was required despite the patient's history of a ruptured AVF. After a few hours in the cath lab, the situation appeared stabilized, marking the end of a very complex neurointerventional procedure. Final DSA showing acceptable results. Post-procedure complications included extensive arterial dissection and progressive femoral hematoma resulting in hypovolemic shock and extensive pectoral hematoma from a central line. Vascular surgery intervened and reconstructed the femoral artery. The patient was stabilized after 10 hours.